you would need to have a diagnosis of obstructive sleep apnea. You would need to have a BMI 30 or above in most instances. And I think that if you're looking for that sleep apnea cure, the people who are going to respond most and best are those who have weight loss from the soft tissue airway that contributes to their sleep apnea disease burden.
In today's interview, you're going to learn so much about the role of Tirzepatide, also known as ZepBound, which is the brand name, and its role in treating obstructive sleep apnea, and how it fits into sleep apnea treatment. My friend and colleague, Dr. Audrey Wells, is back on the channel today. She is amazing. She's a board-certified sleep medicine doctor. She's board-certified in obesity medicine. She's also a certified life coach through the Life Coach School. She helps people make decisions about treating sleep apnea in a way that allows them to get healthy sleep with ease. She has her own personal experiences with sleep apnea, with CPAP, with insomnia. She's got an amazing platform called Super Sleep MD with lots of free resources for patients to learn about different ways to sleep apnea. You are going to learn so much from this interview with Dr. Audrey Wells. If this type of information is helpful for you, then subscribe to this channel and click the like button. Doing so helps get this information out to more people because it feeds the algorithm. Take a second to do that, and let's jump into the interview. Audrey, I am delighted to have you back on the channel. We've done a few videos before, but for anyone who doesn't know you, could you tell us a bit about your background and what you do?
I'd love to. Yeah, I've been in service to people who have sleep disorders for coming up on 20 years now, and it's a real passion of mine. I would say I have special interests in sleep apnea, insomnia, and COMISA when the two conditions mix. And of course, what we're talking about today, obesity medicine treatment, has always been part of my practice, as I like to look at the whole person and their situation as it pertains to sleep or sleep disorders.
You have a really unique background with sleep medicine and obesity medicine board certification. So I think you're the perfect person to talk about this topic, which we're addressing today, discussing Tirzepatide and its role in sleep apnea treatment. So first of all, what is Tirzepatide and how does it work?
Tirzepatide is part of a class of medications called GLP-1 agonists, but Tirzepatide is a little bit unique in that it is a dual receptor agonist whereby GLP-1 and GIP receptors are being targeted. It is an injectable medication, and there are two forms that exist in the brand names Mounjaro and ZepBound. ZepBound is the medication with weight loss as the indication.
When it comes to obstructive sleep apnea, we know that weight is a factor. It's not always a factor, but it can be a factor for many people with obstructive sleep apnea. What is the role of Tirzepatide or ZepBound in treating obstructive sleep apnea, and how much weight loss can a physician or a patient expect to experience on that medication?
I really want to let some of my enthusiasm for this come up to the surface because historically, when I would be seeing people who had struggles with their sleep and their weight, there was always this kind of feeling like it was their fault. And it's part of like the internal and external obesity bias that exists, whereby there's this message that your medical condition is due to your weight. And if you could just have enough willpower or adhere to diet and exercise with enough fidelity, or maybe you're short on motivation, there's always this assignment of kind of judgment or blame on obesity when it relates to medical conditions. But here we're talking about sleep apnea. So when I counseled people in the past, it was like, okay, there's the calorie deficit and you need to exercise more, and there's some medications available. But I think what really is exciting about this new landscape is that these injectable GLP-1 medications are now highly effective. So you asked how effective? Well, with Tirzepatide, the study that came out last June of 2024 in the New England Journal of Medicine, showed that most people were getting 20% of their total body weight reduced. So in other words, if you're a 250 pound person, 20% of your body weight is going to be 50 pounds lost with the use of Tirzepatide. And now this represents another tool for sleep apnea management because as the pairing of obstructive sleep apnea and the clinical condition of obesity is very high. However, there's a myth here that I want to dispel, which is that all people who are heavy will develop sleep apnea. And then the converse is also true. If you don't have an issue with your weight, then you're immune to developing sleep apnea. So I really see the availability of medications like tirzepatide and tirzepatide specifically as a tool for someone who wants to improve their sleep, wants to improve their health, and potentially reduce or eliminate their sleep apnea. I think that's really important.
That's really helpful. And I just wanted to highlight again what you were saying about the weight loss piece and it almost being perceived as a character flaw or a lack of willpower. And I even remember working in sleep clinics and remembering the patients being told that once you start CPAP, it's going to be easier for you to lose weight. And I was taught that in my fellowship. And then out in the real world, I'm seeing patients struggling with weight. They're starting their CPAP or obstructive sleep apnea treatment, and they're still struggling with weight.
Mhm.
So it is really exciting to have this tool available. Are there mechanisms of tirzepatide beyond weight loss that are helpful for sleep apnea? In other words, is it doing other things other than weight loss
Yeah.
that's helping patients with their sleep apnea?
It's such an interesting question. And I think the answer is yes, although we don't understand it completely right now. This is still pretty early days for using sleep apnea and weight management treatment in one. What I can tell you is that tirzepatide seems to have some anti-inflammatory benefits, and that could potentially be one mechanism whereby a person who's using it has some improvement in their sleep apnea. There's also potentially a fluid distribution component whereby you're not hanging on to excess fluid as much, and so your sleep apnea could benefit that way. We can go over some of the details of the study a little bit if you want, because what I want to really bring home is the question that I get most often, which is, if I lose weight, will my sleep apnea be cured? Do you want to go in that
Yeah,
direction?
let's talk about that.
Yeah, so just to set up the background a little bit, the SURMOUNT-OSA trial is the trial that whose results were published specifically showing the effects of tirzepatide in people who had moderate to severe obstructive sleep apnea. So this was a really great study with two clinical arms. One arm, people were using CPAP baseline, and in the other arm, people had sleep apnea also, but were not treated. Okay, so all people in the group had moderate to severe sleep apnea, one arm with CPAP treatment, the other arm with no treatment. And I want to just circle a little caveat here, which is that the amount of CPAP treatment or the frequency of CPAP adherence was not described. So that's a little bit of a study limitation. But these people had very significant sleep apnea. On average, the AHI, apnea hypopnea index, was around 50 events per hour, as defined by the American Academy of Sleep Medicine scoring system. They had a sleep study at the beginning of the trial. They had another one at 20 weeks, and they had the last one at 1 year. And these were all in-lab sleep studies, which is important because there can be a lot of variability in the accuracy of home sleep tests. So I think that really grounds people in the idea that this is well-defined sleep apnea disease burden. So tirzepatide is an injectable, as I mentioned, and there's necessarily a ramp-up period. So you start with 2.5 milligrams and then go to 5, 7.5, and then 10. And so people usually end up at the 10 milligram to 15 milligram per week mark. And by the 1 year conclusion of the study, these people who had an AHI of about 50 and in general, a BMI of about 38, 39. They all showed weight loss. It was in line with what was previously demonstrated with some of the original studies with tirzepatide. So in other words, they were losing 20% of their body weight. And their AHI was cut in half. in general. So results were slightly better with the CPAP group. And again, we don't know how much CPAP the CPAP arm was using. So slightly better results with the CPAP in tow. And another important thing to contextualize with this is in the placebo arm, so people who got sham injection, they lost weight too, and they had reduction in their AHI too, and it was less. But all of the people in the study were supported with lifestyle education. They all had a 500 calorie deficit in their diet every week. And they were all required to have 150 minutes of exercise per week. So there was that foundation of lifestyle choices that really set them up for success. And so in the end, I think that when you look at your expectations of what can a medication like tirzepatide do for me, you can expect weight loss in most cases. Doesn't work for everybody. No medication does. But it's a really exciting impact on obesity. It's a really meaningful clinical change in sleep apnea severity. And I think if you do these things on the backdrop of healthy lifestyle choices, diet, and exercise, your chances of success are increased. Now, this brings me to the final point. How many of these people got rid of their sleep apnea? So what was defined as like the endpoint cure was bringing the AHI down to less than 5, which is considered normal breathing during sleep, or having an AHI between 5 and 15, but no excessive sleepiness as defined by a normal score on the Epworth Sleepiness Scale. And what was demonstrated was that about half of the participants were able to meet one of those two criteria. Either AHI was normal or the AHI was in the mild range and they didn't have excessive sleepiness. So in that situation, you have the option about whether to treat your sleep apnea. And I think for that reason, people are motivated to come into that outcome.
In your practice, what have you seen with your patients? Are you using tirzepatide, and what sort of outcomes are you noticing?
So people are enthusiastic about this as long as they get over the idea that it's an injectable medication. That seems to be a barrier for a lot of folks. And I think that's reasonable. You really have to be personally invested in this type of treatment and prepared for what lies ahead. The medication is very well tolerated, very few side effects. The most common side effects are gastrointestinal, so nausea, vomiting, some diarrhea, constipation. And I think it's worth noting that the side effects that are common can be mitigated with a much slower ramp up time and persistence or giving anti-nausea medication because they usually go away. So if you just stick with it, those side effects usually go away. Weight loss in the ramp-up period, which is maybe about a month or so, is between 2 and 5%. And then after that, you are on a steady trajectory until around the year mark. There doesn't seem to be much weight loss beyond that point. So you stabilize and plateau around that 1 year mark. Coverage has improved, meaning insurance coverage for the medication, and the shortage of the medication has been resolved. I think it's worth stating that when there was a lot of excitement, and especially when the branded medication, tirzepatide comes from Lilly, when the branded medication was in short supply, there were a lot of companies going with like the compounded form of the medication. And it's worth noting that this is a little bit of a wild card because these compounded forms are not necessarily regulated like the branded form is, and they weren't studied. These were not the medications studied in the clinical trials. So if your response is atypical or if your side effect profile is different, that could be a reason. But now that the shortage has resolved, it seems that access has improved. And I think we're just seeing a ramp up of people who are starting to consider this and even go forward using tirzepatide.
Excellent. So I know some physicians, practitioners, and patients are probably wondering, okay, so if I'm going to start tirzepatide, am I still going to need to use CPAP down the line? Or like, would this potentially be a way for me to get off my CPAP or not have to use it or not have to use other things like an oral appliance? How would you counsel those patients on those questions?
I have an opinion about this, but I think that when people come to me with their preferences, then I work with them, of course. But here's the thing. If you don't sleep well, if you have an untreated sleep problem, you sabotage your success a little bit. And because if you aren't getting that brain refresh that comes from healthy sleep every night, you're less likely to make good choices when it comes to food. You're less likely to strap on your earbuds and go outside and walk or do strength training. You're less likely to manage the day-to-day things that you need to do to have healthy weight loss. And when you look at the trajectory of weight loss for a medication like tirzepatide, we're talking a year before you come to your final endpoint. And so if you leave your sleep apnea untreated for a year, that's a problem in my eyes. Now, CPAP is a challenge for people oftentimes. Not some people adapt to it really quickly, and some people are surprised they adapt to it so quickly. But I think that people should understand that, first of all, if you're setting yourself up with healthy sleep from the beginning, you're going to have a better outcome. And second of all, just because CPAP is indicated in the beginning doesn't mean that you couldn't switch to a different sleep apnea treatment later. And this medication, this weight loss is not going to cure everybody. So there remains the very real possibility that at the end of your weight loss journey, you will still have some degree of sleep apnea that needs to be treated. My fear is that a lot of these folks who are going for weight loss go to their primary care doctor, they go to an online clinic, they go to somewhere, and they never have a sleep study because they think that the weight loss is going to resolve all their sleep problems. And it's just not true. So I try to support people the whole way through and encourage them to support themselves as well.
That's such a great point, and it's a sensible approach, really, looking at all the different factors involved. So, who's a good candidate for tirzepatide?
I think there are specific indications. So you need to, for obstructive sleep apnea management, you would need to have a diagnosis of obstructive sleep apnea. You would need to have a BMI 30 or above in most instances. And I think that if you're looking for that sleep apnea cure, the people who are going to respond most and best are those who have weight loss from the soft tissue airway that contributes to their sleep apnea disease burden. Also, people who tend to carry a lot of fat in their midsection. So one thing that really contributes to tough breathing mechanics is having a bigger belly that pushes up on the lower part of the diaphragm, makes it hard for the diaphragm to expand and contract, opening up the lungs. And then you lose some of that tracheal traction. So that makes the airway more collapsible. So people who lose fat from these areas, belly and surrounding the neck, are going to have a bigger response. People who have more sleep apnea are going to have a bigger response. And I think it's worth noting that the AHI is pretty limited when it comes to sleep apnea severity. There's really a parallel there between AHI and BMI being relatively superficial metrics. And so there's this concept of hypoxic burden that's now coming into our knowledge. And this was actually one of the outcomes, secondary outcomes measured in the SURMOUNT-OSA trial. They saw improvements in hypoxic burden, which I think are really exciting because that's something that drives inflammation. So if we can reduce that and stabilize oxygen levels, you're going to have a great result too. So just to recap, weight loss from the belly and the neck, higher AHI or more severe sleep apnea, these groups are going to respond most and best to.
Okay, that's super helpful and very clear. And On the flip side, you spoke a little bit about the side effects, GI effects, and whatnot. Are there any contraindications? Anyone who should not be taking tirzepatide?
Yes, people who have a form of multiple endocrine neoplasia should not be taking tirzepatide. Also, there's a different disorder called medullary thyroid carcinoma. These people should not take tirzepatide. Pancreatitis is a caution. You can actually have pancreatitis as a side effect. It doesn't occur commonly, but people who have a history of pancreatitis should really be careful with tirzepatide, certainly get monitored closely. And I would add that people who have a history of disordered eating should also use caution and really get psychological support when they're using this medication, because it's definitely possible to overdo it. And there is an emotional component, not only to obesity, but to weight loss that needs to be addressed for someone who has that pattern of disordered eating.
That's a really important point. And what about patients who are already on something like Ozempic? Is there any research showing how that might impact sleep apnea? Or if someone is wanting to try tirzepatide, they're already on another GLP-1, is it advisable to switch then to tirzepatide? Or what do we know about all of that?
Yeah, so Ozempic is the brand name for semaglutide. And Ozempic and Wegovy are the same medication, but Ozempic has a diabetes indication. The main difference with semaglutide is that semaglutide is a mono GLP-1 receptor agonist, so you don't get the added benefit of the G dual receptor agonist. So if you want to switch from Ozempic to Mounjaro, which is the diabetes indication form of tirzepatide, you can certainly do that to see if more weight loss benefit is accessible. And I would just recommend that you work with a obesity medicine certified physician, someone who is well versed in the translation of one medication to another, because certainly there's such an appetite for these medications that a lot of clinics have popped up. And it may be a little bit premature that they have experience and they have the backing academically to handle that switch.
Okay, that's really helpful. And so for the physician who's maybe considering prescribing tirzepatide to their patient with sleep apnea, what are some considerations with regard to insurance? I know you spoke about insurance a bit already, but is there anything they should take into consideration with regard to prior authorizations or other barriers that they might be up against?
We're still dealing with barriers, and this is a moving target. My hope is that it's moving in the right direction. Lately, there's starting to be more and more Medicare approval. Other third-party payers, or I would say they're surveying the landscape right now. So I think coverage is improving. The cost of the medication from the Lilly Direct Pharmacy is about $500 per month. So that's an improvement even over a few months ago. And sometimes there's benefits that you can get, especially if you kind of subscribe for a longer term. So I'd encourage people to look at that and factor in cost when they are making a decision about the medication, because it's certainly not pennies. Now, later this year, I do expect to see some of the oral medications become available. There's some pretty exciting clinical trials going on right now. And the oral medications should be less expensive. They'll have shorter half-lives and potentially some more dosing, fine-tuning that can help not just with the initial weight loss, but the long-term maintenance of the weight loss. And I find that this is a common misconception that people prepare themselves for the year of weight loss, but don't factor in the idea that obesity is a chronic disease, just like sleep apnea is a chronic disease. So you will necessarily be fighting your internal mechanisms to protect that fat mass. I mean, it's a pathologic mechanism, but you are going to need obesity management for the long term. And so factoring that into your decision making is relevant, I think.
Yeah, absolutely. And along those lines, we're learning so much more about the pathophysiology of sleep apnea. You were speaking about how the AHI is is an insufficient metric in many ways. And now we're looking at hypoxic burden. Do you see a direction where sleep apnea might be conceptualized as a metabolic condition? What are your thoughts about that?
I, in my mind, there's no doubt that sleep apnea is a metabolic condition. And the truth is, some people describe sleep, eating, and physical activity or exercise as like a three-legged stool, right? I'm biased because I know what good sleep can do for you, but I look at sleep as the foundation of everything that we do because sleep is for our brains. It affects our emotions, our decision making, our behaviors. And if you're not washing your brain every night and resetting your faculties, then you're simply not going to succeed with a health journey. So I absolutely see sleep apnea as a metabolic problem. And I think it's exacerbated by obesity.
For the practitioner or the patient who's maybe considering tirzepatide, what's one takeaway that you want them to leave this conversation with?
Well, I'm going to give you three takeaways.
Okay.
Is that all right?
Yes.
I mentioned that this is a long game. There's no magic beans. There's no magic potion with this. You need to have that backdrop of good lifestyle choices. And part of that is maintaining your muscle mass, not just with protein intake, but with weight-bearing exercises. All of these things are intertwined. I also think that it's worth noting sleep apnea is a multifactorial condition. It's exciting that we're addressing weight because your body weight is a modifiable risk factor, but we haven't talked about the other two of the top three risks for sleep apnea. One is age, and the other is your biological sex. So as a person ages, even if they've resolved their sleep apnea with weight loss, as a person ages, your risk is going to go up again. So you need to recheck. And if you're a woman or a woman who's in the postmenopausal season or a man, you need to recheck because you are having risk factors for sleep apnea unrelated to your weight. And then the third point I would make is that there's very good data showing if you don't continue to manage your weight, medication or not, your weight will return. Weight regain will happen. And when the weight regain happens, your sleep apnea will come back. And the problem there is that if you're doing like this yo with your weight, with every cycle of weight regain, you are less metabolically active because what you regain is fat. What you lose is about 70% fat, about 30% muscle. So we know that weight gain, regain dynamic is really problematic. And that's another reason I so wish that people would protect their sleep and treat their sleep even as they're managing their weight. So that was 3 points. This is a long game. Your sleep apnea is a multifactorial condition. You got to retest with age. You got to retest if you're postmenopausal or a man. And your weight can come back if you don't keep battling your obesity condition.
Great. That's so helpful. And I just wanted to highlight again the point about retesting, because I'll hear this from patients or even from colleagues that, well, this person had a sleep study 5 years ago and it was negative, or 7 years ago and it was negative. And I tell people that, well, it's like checking your blood pressure 5 years ago. That's not really representative of what's happening now. So it is something that we have to keep an eye on and keep looking into. So Dr. Wells, this was so helpful. Thank you for sharing your knowledge and expertise on this topic. If people want to work with you or learn from you, where can they find you?
So my company online is called Super Sleep MD at supersleepmd.com. In that website, you'll find a free membership where you can go in and access some resources that I have for obstructive sleep apnea, for insomnia. Relevant to our discussion today, I have a freebie that says, if I lose weight, can I kick CPAP out of bed? And I think that's a question on a lot of people's minds. One of my talks is called Sleep Loss Cancels Out Weight Loss. And I really want that to be the take home message for today. Sleep is so important. Sleep is foundational to health. And because of the bidirectional relationship between sleep apnea and weight, you really can't just treat one of those things. It's been a pleasure to speak to you today, and I hope that we get to talk again soon.
Thank you so much. And we'll put the links to those freebies and the free group in the video description. So everyone go and check out Dr. Audrey Wells at Super Sleep MD. Check out her free resources. And thank you again for spending your time with us today.
My pleasure.